Okay, good morning. Thanks to Klaus and the Bern team for having me. So I'm going to present our work on three-dimensional predictors of FAI disease progression in the contralateral hip. And I'd like to acknowledge my co-authors here, standard disclosures. So we continue to understand the pathophysiology of FAI more and more since its original description by Gans and colleagues. CAM-type FAI is clearly established as a risk factor for osteoarthritis. But we still have a long ways to go. Many or most patients with CAM morphology never develop hip OA or even hip pain. We don't understand the role of activity level in the development of a symptomatic disease, as well as three-dimensional imaging and deformity characterization, including femoral version, isn't well established with any of our natural history studies. If we think about the pathophysiology of FAI from its development, early disease, transitioning to symptoms, later disease, and eventually osteoarthritis, we know a lot about the early formation of disease from the work here in Bern, as well as a fair amount about this later stage in the development of arthritis, our patients that we treat. But we really don't know a lot about this early development of symptoms, why some patients develop symptoms and others don't. So there are a variety of strategies to look at this: clinical predictors, molecular biomarkers, imaging biomarkers. So in this line, we're going to talk about clinical predictors of disease progression in this area. So the contralateral extremity is a great model in orthopedics. The rotator cuff has been well researched using the opposite shoulder at our institution and has taught us a lot about the pathophysiology of disease. The contralateral hip in FAI is a great model. It's certainly a higher risk model than the general population. We can comprehensively look at patient and imaging factors in this setting. We do know some about the contralateral hip in FAI. Alan looked at this. 78% of hips had contralateral CAM morphology. 26% of those had pain. The alpha angle appeared to play a role in this. John's looked at this in a cohort undergoing total hip on one side, looking at the other hip. 34% had contralateral pain. Klingenstein as well, 20% rate of surgery in the other hip in FAI, a number of factors associated with that: males, younger age, alpha angles, and decreased acetabular version. But these are all retrospective looks at this in a cross-sectional approach. We published this a few years ago looking at this longitudinally in an FAI cohort, about 150 hips, about 3 years out, using plain radiographs, no three-dimensional imaging. We saw that about 20% of patients have symptoms at baseline, another 20% develop them over the next up to 5 years. And a variety of factors predicted this, including head-neck offset ratio, alpha angle, and hip range of motion. But more and more we understand that three-dimensional morphology plays a critical role in the disease, including proximal femoral morphology, femoral version, and acetabular morphology. The purpose of the current study was to investigate the role of these three-dimensional hip morphology factors in the development of symptoms in the contralateral hip in patients with FAI. So we utilized a cohort of 161 patients from 2013 to 2018. All patients had low-dose CT that gives us data on the contralateral hip. They were excluded with previous surgery on the contralateral hip, age greater than 60, or the presence of dysplasia lateral center is less than 20. So we looked at endpoints, development of symptomatic pain, which we defined as moderate or greater pain, so not slight or mild pain, but just moderate or more severe, as we found this generally is going to persist, as well as the conversion to surgery. We utilized Dionic's plan analysis, which Chris Larson and others have published nice normative data to compare our hips to. Low-dose CT nowadays can be used very regularly with 90% reduction in radiation compared to traditional CT. So this gives us a sense of a quantitative analysis of proximal femoral morphology, femoral version, as well as acetabular morphology. Statistically, we looked at this as far as Kaplan-Meier survival analysis, as well as predictors of symptoms, both in univariate and multivariate manner. So we looked at 133 hips that were available for follow-up on an average 2.3 years, range 1 to 6. These patients on average are 29 years of age, predominance of female hips in this cohort. So if we look at this at baseline, about 19% of patients had moderate or greater pain at the time of presentation of ipsilateral surgery. And then if we look at this at follow-up, this increases to about 35% over that next period. If we use this in a survival analysis, we can see generally about 20% symptoms at baseline with 5% per year increase in the rate of symptoms over that next 5 years. And this is very similar to the curve we saw in our previous data. If we overlay these, they're nearly identical, so very similar progression. If we look at surgery, about 20% of hips in the cohort had surgery. If we look at survival, 15% have surgery in the first year, and then you start to lose about 5% per year after that. So what factors drive symptom development? So we looked at the rate of symptom development in different groups. Many things you would think maybe are important did not appear to be important in our data, including sex, BMI, activity level, range of motion, and follow-up length. UCL activity score had previously been important in our data. In this data, a trend towards more symptoms in the higher active population, which is actually the opposite of what we saw in the earlier cohort. Similarly, range of motion did not appear to be significantly different between those hips with symptoms and those who never developed symptoms. So these 4 things start to come out in the data. Age, the alpha angle greater than 55 degrees at the 1 o'clock position, abnormalities of femoral version, less than 0 or greater than 20, and then decreased acetabular version. So we'll dive into these in more detail. So here age, lower age was more predictive of symptoms. Under 30, 26% go on to surgery. Above 30, only 10%. So that was significant. If we move on to alpha angle, this is all in univariate analyses. The 1 o'clock position, for some reason, appears to be much more important than the overall alpha angle. We're looking at this near circumferentially on the femoral head. So an alpha angle is slightly greater in those that develop symptoms. If we look at this relative to a 55-degree cutoff, it's much more significant, an odds ratio of 2. And then this contralateral hip, this is a breakdown. About half of the hips have an alpha angle above 55 at this position, half do not. This doesn't hold at these other positions, including 1230 in the maximal alpha angle. Femoral version, interestingly, appears to be higher rates of symptoms in those with true retroversion, which is only about 9% of the cohort, but also in those hips with increased anteversion above 20, which is relatively common in this group, female predominant group, 38%. So if we dichotomize this, 0 to 20 being our normal range, if you're outside of that normal range, you have a much higher rate of development of symptoms at 45%. So if we're looking at alpha angle and femoral version together, if you're normal in both, your rate is very low. If you're abnormal in both, your rate becomes very high in the 50s for the percent. Decreased acetabular version, central acetabular version, also comes out as a statistical trend that will come in the multivariate as well. Interestingly, additionally, slightly decreased posterior coverage is present in those hips with developing symptoms. Anything around the anterior coverage was no different between those with symptoms and without. So if we combine this, looking at these factors independently, so combining them into a multivariate model, the things that remain significant include femoral version abnormalities, so again, 0 or below or above 20. Alpha angle at the 1 o'clock position, greater than 55, remains significant, odds ratio of 2. And then decreased acetabular version, 1.08 for each degree decrease in acetabular version. So these 3 factors together are all significant, but still explain only a small amount of the variability in this data. So there's definitely still things at play here that we don't understand. If we look at the risk factors for surgery in a similar multivariate manner, the alpha angle remains significantly associated with this at that 1 o'clock position, and then age becomes more important. So again, the lower age, higher risk of going on to surgery, and similarly together these factors only explain a small portion of the overall variability. So there are limitations of this approach. This is a relatively short-term follow-up in this cohort. We're relatively underpowered as you start to get into some of these less common subgroups. And there's still a large amount of unexplained variability in the model. We also look at this as far as the development of pain, but we don't know, is this pain truly FAI or some of this potentially instability driven, especially with increased femoral version being a factor. So in summary, we saw a rate of symptom development in the contralateral hip similar to what previously published, 20% at baseline, 5% each additional year. The alpha angle, femoral version, and acetabular version appear to play a role in the development of symptoms. 3-dimensional hip morphology appears to be an important driver of the pathophysiology of FAI, and really continued research efforts will continue to need to understand more this full spectrum of the pathophysiology of FAI. Thank you.